So today we are going to discuss about the ptosis. What is ptosis? Ptosis is the dropping of upper eyelid. Whenever we are talking about the ptosis, it's always about the upper eyelid. So what is the normal location of upper eyelid? So we can say that they are low as compared to their normal or standard level. Normally, the upper eyelid covers about 1/6 of the cornea or about 2 millimeter, according to some books. So we first of all we will classify the ptosis. So ptosis can be classified mainly on two bases. One is congenital and other is acquired. So first we will discuss different types of acquired. So acquired can be neurogenic, myogenic, aponeurotic, and mechanical. Then congenital can be also be divided into two. First is simple and the other is complicated. Complicated may be like bilio, like blepharitis syndrome and Marcus Gunn jaw winking syndrome. So first we will discuss about different types of the acquired one. First is neurogenic. So there is some problem with the nerves. Okay. First we will discuss about the Horner syndrome. So in Horner syndrome there is a disruption of nerve pathway from the brain to eye. Mostly it affects the sympathetic one. So as you can see in the pic, this ptosis like this one. This is ptosis. This is normal. Okay. And this is also another picture of the Horner syndrome. So there's another thing that you can easily see on this side. On this side you can see there's a lot of sweat, but on this side there's no sweat, because normally we have already read in our medical school that Horner syndrome has three things. First is ptosis, other is meiosis, and the last one is anhydrosis. So as there will be no sweat, so this one is the affected one, and you can see on the other side there is normal sweat present, but on this side there is no sweat present here. So this is Horner syndrome. Now the other type is myogenic. So myogenic there is some problem with the muscles. Okay, first of all we will discuss about the most important one, myasthenia gravis. So what's happened in myasthenia gravis? So this picture, this one, this is the picture of neuromuscular junction. So in neuromuscular junction there is nerve. Let me change the color. So this is the normal nerve and this is the muscle. So as the nerve impulse reach there the release of acetylcholine. But in the myasthenia gravis there are some antibodies that are produced that will affect this acetylcholine receptor. So when the nerve impulse will reach the end plate potential, in this case is very large, but in this case is very small, so muscles can't work properly. So in this case we will see the ptosis, and there's an also diplopia present in this case, because the normal alignment of both of eyes is disrupted, due to which diplopia is also present. So myasthenia gravis affects the levator, palpebrae superioris, and extraocular muscle also. There are some two main points about myasthenia gravis also, that the ptosis worsen on prolonged upper gaze. So if the patient is seeing upward for a long time, then your ptosis will worse, and also worse on the end of the day. Like the myasthenia gravis, the Lambert-Eaton syndrome, the ptosis will also occur. So this is the picture of Lambert-Eaton syndrome. There will be also the presence of antibodies, but this time this calcium channel will be affected, due to which, like you can see, these are the antibodies and they are affecting the calcium channel, due to which the nerve impulse cannot reach and muscle could not be able to work properly. The other condition is CPEO, which is chronic progressive external ophthalmoplegia. Like you can see in this picture, with the passage of time, as you can see here, you can see a lot of ptosis. So in this condition the ptosis occur with the passage of time. The other condition related to the muscle is myotonic dystrophy. It also affects the muscles. So as you can see in the picture, there is ptosis present and there is drooping of eyelid. Now we will discuss the next part, which is aponeurotic ptosis. So this is the most common one. So there is descent of the aponeurosis. So aponeurosis of LPS is mainly affected. So it can be due to different causes, like postoperative. So if there is any operation of the eyelid or eye, so this can happen. Like it can occur due to old age, or it may occur due to any traumatic injury of LPS aponeurosis. One of the feature of this is, like, there is high lid crease, as you can see in this picture. So this is the lid crease. So lid crease is very high as compared to normal, which will be like that, but in this case the lid crease is very high. The other is mechanical ptosis. So due to any mechanical problem, like if there is pushing mechanism, so if there is any tumor, lesion, or neurofibroma, like you can see this one, this can cause ptosis. Now we will move toward the other type, the congenital one. So first is the simple. So in this, the problem is with the LPS, levator palpebrae superioris muscle. So if the problem is with LPS, so if it could not be able to develop properly, so in that case there will be absent lid crease, because LPS could not be able to develop properly. So LPS is the main muscle that cause the upper lid crease, so there will be absent upper lid crease. Also there is lid lag on the ptosis side. So we will discuss about the lid lag. So if this is the eyeball and this is eyelid on both side, so if I move my eyeball downward, the eyelid will have to move downward, and if I move my eyeball upward, the eyelid will have to move upward. But in this case, if I move my eyeball downward, the side which has ptosis, the eyelid could not be able to move downward. Even it could not be able to move upward, but it could not be able to move downward with the eyeball. So there is lag. We call this condition as lid lag. So this occur mainly because LPS could not be able to develop properly, so it could not be able to relax properly, due to which it could not be able to move downward also. So we call this condition as lid lag. Now we will move toward the complex condenser. So first one is blephαρomyosis syndrome. So it is an autosomal dominant disease. It is due to effect of FOX gene present on chromosome number 3. So it has following features. First one is blephαρomyosis, which is the shortening of the horizontal length. So if it is the horizontal length, if there is shortening of the horizontal length of the eye, we call this condition as blephαρomyosis. The other is epicanthus inversus. So what is epicanthus inversus? You might have seen some Asian people. You can see like their eyes are small as compared to us. So in that case, normally the upper eyelid fold downward, due to which the size is small. But in case of epicanthus inversus, the lower eyelid move inward, and due to which the size becomes small. So we call this condition as epicanthus inversus. Inversus because it is due to the lower eyelid. The other is ptosis, and the other condition is telecanthus. So what is telecanthus? So if this is middle canthus and this is middle canthus, so if the length between two middle canthus decrease, we call this condition as telecanthus. But we have to differentiate it from another condition, which is hypertelorism. So the basic difference between both of these is, in both cases the medial canthus, the length between both medial canthus decreases, but the main difference is, in case of telecanthus, the distance between two pupil will remain same in case of telecanthus. But in case of hypertelorism, the interpupillary distance will not remain same. So this occur mainly due to like telecanthus occur mainly due to the problem of connective tissue, but hypertelorism occur due to the problem with the orbit. So in that case, both of the orbits are far apart. So this is the basic difference between these two conditions, although in both conditions the distance between the middle canthus increases. Now the other condition is Marcus Gunn jaw winking syndrome. So Marcus Gunn was the person who discovered that phenomena, so due to which it is named as Marcus Gunn jaw winking syndrome. So before diving deep into this syndrome, first we have to know about what is syncytial. So it is a condition where two or more muscles contract together at the same time, even though they are controlled by different nerves. Although both of the muscles are controlled by different nerves, but they are moving and contracting at the same time, are different branches of the same nerve. This results in involuntary simultaneous movement of the muscles. So this is syncytial. Now as you can see in this picture, so in the first condition, there is ptosis. As you can see, the eyelid is at lower level. Now when the child opens his mouth, so there is no ptosis, or ptosis vanishes. So this condition is also known as pterygoid levator syncytial or pterygo-oculomotor syncytial, because it is the pterygoid muscle which is present, and the other muscle that is affected is levator LPS and pterygoid muscle. Both are muscle are affected, so we call this like pterygoid levator syncytial, and the other is pterygomandibulo-oculomotor syncytial, because both of these two nerves are involved, like LPS oculomotor and lateral pterygoid, which is supplied by trigeminal nerve mandibular branch. So we can call this disease by these two names also. But what is pathogenesis of this syndrome? So overall its pathogenesis is not understood, so there are basic two theories. So first one theory is there is abnormal connection between two nerves, like mandibular branch of trigeminal nerve and oculomotor nerve. So there is like abnormal connection that develops late in the life. And the other theory is release hypothesis. According to this theory, it suggests that there is a hidden ancient connection in the brain. Like according to this theory, both of the nucleus of these nerves have some ancient connection which is present, and this connection normally disappear, but in this case it doesn't disappear, due to which this phenomenon, this syndrome occurs. Now we will discuss about the lab investigation. So we will go into the lab and do some investigation to know the different cause of ptosis, because ptosis can occur due to so many causes. So these are some of the basic tests that we can perform. So first one, we check for the acetylcholinesterase enzyme. As we have discussed earlier, acetylcholinesterase enzyme actually is involved in, so it is basically involved in destruction of acetylcholine. So both of these tests are based on the activity of this enzyme. We normally stop the activity of this enzyme to check for the myasthenia gravis. So first one is endrophonium artemisinin test. So endrophonium normally acts on acetylcholinesterase enzyme and stops its activity, due to which if the ptosis occur due to the myasthenia gravis, now acetylcholine concentration increase, so muscle contraction will also increase. The other test is ice pack test. As you can see in the picture, in this condition, when the ice pack is placed over the eye, the acetylcholinesterase enzyme activity decrease, due to which acetylcholine concentration increase and ptosis disappear. As you can see, there is ptosis present there. Then antibody testing, because in the myasthenia gravis the antibodies are formed against the acetylcholine receptors, so we can check for the antibodies also. The other test is phenylephrine test. So phenylephrine test is used in case of Horner syndrome, because in Horner syndrome normally sympathetic outflow is affected. Phenylephrine is sympathomyomatic. So if the ptosis occur due to Horner syndrome, if we give phenylephrine, the ptosis will disappear. Now we will discuss about the treatment of ptosis. So first of all, we have to determine the amount of ptosis. So we determine it on the basis of the eyelid. So if the eyelid is like 2 millimeter drop in eyelid, we say it as mild. We say it as moderate if it is 3 millimeter, and severe if it is 4 millimeter. We also check for the activity of levator muscle based on a method known as Burki's method. So in Burki's method, first we ask the patient to look downward as far he can look. Now we ask the patient to look up, and we measure the movement of the eyelid, and we, like as you can see in the picture, like if it is normal, it is 15 to 18, like it is good. In case of, in some books like 9 mm or 12 to 15, it is fair about 5 to 8 millimeter, and the activity of LPS is very poor if it is less than 4 millimeter. So normally if the problem is with the muscle, we have two things that we perform. So there can be two conditions: either muscle is underperforming or it is overperforming. So if in the case if the muscle is under action or performing less, what we do is resection. So in resection, we basically cut the small part of the muscle. In this way, the whole of the action of the muscle increase. And if the action of the muscle is more, so in this case, we go for resection. In resection, if this is the insertion, we place the muscle like there, even far away from its normal insertion. So in this way, its overaction decreases. So there are basically two processes that we can perform on the muscle. But in the case of ptosis, as we know, the muscles are underperforming. So we go for resection of the muscles. So normally if we go for the surgery, so we have basically three options. Like we can go for the LPS resection, we can go for the Muller's muscle resection, or we can go for the sling operation. So first of all, we will discuss about what is LPS resection. So in this case, we use mainly Burki's method to access for the LPS muscle. As we have discussed like this, we will see how much action or how much powerful is LPS. Normally we go for the resection of the LPS for all of these cases, but not for this one. So if the muscle is so much weak that it would not be able to perform like 4 mm, so we can't go for resection of that muscle. So in case of LPS resection, if the muscle activity is like less than 5 mm, no LPS resection. So we normally perform this for moderate ptosis. The other is Muller resection. So if not, LPS is working normally, so we can go for Muller resection. We do it in case of mild ptosis. But in case of severe ptosis, like in that case, if the LPS is not working properly, so we go for sling operation. We will discuss it later part. So first of all first one is Fasanelli's servant procedure. So in this case, we normally go for resection of LPS muscle. So indicated for mild ptosis with good elevator function. Okay, no, sorry, we do not go for resection of LPS. We go for resection of Muller muscle. If LPS is working normally, there is no problem with the LPS, so we will go for the resection of the Muller muscle, also with torsals and the lower part of Muller muscle and overlying conjunctiva. So as you can see in this case, so if LPS is working normally, we will go for the Muller muscle resection, also with the border of torsals and overlying conjunctiva. The other is levator resection. So if the ptosis is due to levator LPS muscle, so we go for resection of the levator muscle. So in this case, it is, as you can see, it is contraindicated in the patient. There must be 5 mm of the LPS function, as we have discussed earlier, that it can move the eyelid at least 5 millimeters. So in this case, we go for this shortening of levator complex, as you can see in the picture. The other is frontalis bro suspension. We also say it like sling procedure. So in this case, if LPS is not working properly, like it could not be able to elevate the eyelid up to 5 millimeter, so we go for another procedure which is known as sling procedure. So in this procedure, like as this is written, severe ptosis with poor levator function 4 mm or less, or in case of Marcus jaw winking syndrome. So in this case, what we do, we connect the eyelid with the frontalis muscle. So now, because LPS is not working properly, now we connect the eyelid with the frontalis muscle. So normally this can be done by using two things. First is facial letter, which is best and ideal. Otherwise, silicone can also be used for this process. Another process is aponeurotic strengthening. So if there is some problem with aponeurosis of LPS, so we go for this process. So if all the process we have discussed are because of problem with the muscle. What if the problem is with the nerve? In this case, the problem is the nerve. we can't go for any other procedure at the time because nerve injuries take a lot of time to recover. So in that case, we go for another thing which is known as clutch glass. As you can see, these are the clutch glasses. So these glasses have like these. So before, like this ptosis, but when these glasses are used, ptosis is improved, as you can see in this picture. So our last topic is pseudotosis. So when the eyelid look droppy, but the dropping isn't by a problem with the eyelid lifting muscle. So it doesn't because of eyelid lifting muscle due to LPS or molar muscle. So in that case, we say this condition as pseudotosis. So it can be due to different problem like lack of sports or weak tissue or bone. Like other condition, if the eyeball is sunken into the socket, or if the eyeball is shrunken, or if the eyeball is small as compared to normal from the birth, or if there is contralateral lid retraction, or there is ipsilateral hypertropia, or brow-ptosis if eyebrow drops, or dermatocalcisis in which there is extra or loose skin on the upper eyelid, which can be